injections, and they really didn't see much. Richie, using different dosing, says he's seeing more. I like Richie, but again, I find that his recommendations keep changing, and I haven't been impressed with the effectiveness. And my recommendations keep changing too, but I have been impressed with the effectiveness as we go. Anyway, I'm just teasing. But it's the erythropoietin, maybe there's a subset that can use it, but I do these basic things first. Get their iron okay, get their vitamins, nutrition status okay, optimize thyroid and testosterone. Then if you need erythropoietin. Okay. So now, even though the cardiac dynamics are not the main thing, secondary to the red blood cell mass, hypovolemia, I think it still is good to optimize cardiac function. They attributed 91% to the hypovolemia and red blood cell mass, treat the other 9% anyway. Ribose, CoQ10, acetylcarnitine, B complex, magnesium, standard IVs have a marked effect. Magnesium increases ejection fraction 5%. That's a lot. CoQ10 increases ejection fraction. Ribose, all of these things, thyroid, testosterone. So you notice the same things, we're getting double duty out of them. We're going to increase red blood cell mass, increase their symptoms, and help muscle function. And then another part of the dysautonomia is neurally mediated hypertension and POTS. Same treatments, salt, hydration, IV fluids, dexedrine for the autonomic dysfunction, sometimes the SSRIs. In refractory cases, Zoloft has actually been shown to help neurally mediated hypertension, so is Prozac. You'll find 1/3 of our patients will feel better on antidepressants even if they're not depressed. But on the other hand, they already have enough sexual dysfunction, weight gain, and other things. These are way down on the list of what I'm going to be using.
Because of the neurotransmitter.
Because of the neurotransmitter effects will affect the autonomic stability. The low serotonin is associated with the dysautonomia. You can get 5-HTP, get the same benefits without the toxicity. But I haven't seen studies on 5-HTP in NMH. But again, these autonomic dysfunctions, I do not bother with tilt table testing, reasons I'd mentioned earlier. Other problems with dysautonomia, again, decreased peristalsis. So the spastic colon, constipation, the small intestinal bacterial overgrowth is coming from the decreased peristalsis. If you think about it, the small intestine is almost as sterile as urine. To make the diagnosis of overgrowth in the small intestine, if you have 10 to the 6 bacteria, that's the cutoff you use for UTI when you do urine culture. They use the same cutoffs for saying the small intestine is infected. So candida, parasites, big players here as well, but low thyroid and the decreased peristalsis from the autonomic function are going to cause the bacteria to back up into the small intestine because the peristalsis washes it into the colon where it belongs. And it's just like if you have a bladder obstruction. What are you going to get? Infected. Gallbladder, if the duct's blocked, what are you going to get? Infection. And if the small intestinal outflow, even because of apnea, because of ileus, because of decreased peristalsis, is diminished, you're going to get small intestinal bacterial overgrowth. Now, we had looked at hydrogen breath testing, which was a real flop. That was another one. And, so there's things we hear about that they're kind of the flavor of the day that I've learned to take with a little bit of a grain of salt. I like them to withstand the test of time. I do want to do a thyroid update too. We're going to wrap up in a little bit. Feel free to take questions because we're kind of doing Q&A with it. Thyroid glandulars are rapidly becoming unavailable. Armour Thyroid is almost gone from the market. Nature Thyroid, West Thyroid, the other are almost gone because they were trying to catch up with it.
One of the companies that I'm aware of that does this independently, their own pharmacy, said that something would be available at the end of this month. Do you know what that's about?
Most of the main companies and the FDA is now rattling chains like they're going to make them unavailable totally. I've heard they want to do, and it's hard to tell what's, this chicken little sky is falling stuff. But this comes from Nancy Showman and from Mary Showman, who's a very reputable source, and she feels that the FDA is just like they want to make estriol unavailable. They want to make desiccated thyroid unavailable.
I've heard the latest is H1N1. They're checking the pigs for swine flu.
God knows. Next they'll be, if they pull the head out of there, well, anyway. But yeah, I don't know that company is. One company was basically delicensed by the FDA. They've been told that this is an investigation of a new drug. They need to put in a new drug application. That's about $800 million that generally costs to develop a drug and put it through the FDA process. It's not patentable. That's a way of smilingly saying, oh, you can stay on the market if you pay the $800 million, but not patentable. Who's going to do that?
And I'm sure you know this as much as anybody, the benefit of Armor was that insurance covered it, whereas the T4, T3, they do not. So
What was the?
the insurance coverage.
Oh, yeah. To me, it's so cheap that was a modest thing. Although the T4, T3, there are issues. But the problem that I'm starting to move away from the Armor a bit, because more and more what I've been suspecting is that the antigens in the glandular in somebody who has Hashimoto's or Graves stimulates the autoimmune disease. And I've been starting to see that. And I frankly, personally, have been kind of moving back away from that a bit. Once Armor did their reformulation, the old product was okay. The new one, it's a medical term, crappy, does not work. Patient after patient is going, besides tasting lousy and not breaking down, it just hasn't been working, and they're getting the thyroid symptoms back. I've been moving more and more. I mean, I'm going to be working with a committee trying to guarantee availability, and block the FDA kind of a thing. There's a group of 25 of us, again, that's coming together on that issue. But I've been thinking that the combination T4, T3 is a better way to go. Potency, purity, and you don't get the antigenicity driving Hashimoto's or Graves. Now, if somebody has a central hypothalamic function thing, more of an argument. For the glandulars, you get the additional benefit of the glandular tissue in helping the thyroid. But I'm getting less and less comfortable with that anyway. So I think the T4, T3 combo, and ITC, when it comes to T3, the potency purity issue is a disaster out there. And one of the only pharmacies that I trust is ITC. And when you go there this afternoon, you'll understand why. Good. Now, Mark, I know I kind of cut you off midstream. Did I kind of get to what you're saying with it? So be aware that patients are going to be coming in, the ones on Armor, saying, I can't get any more, and say, it's probably good, because most of the people have been finding that the new formulation, it's as if they're not taking the thyroid at all. Their symptoms are all coming back. Now, if you can't afford the compounded, use Synthroid and Cetamol, and just adjust the number of pills. But I think the compounded combination, they're less likely to screw it up and come in with arrhythmia. And at the end of the day, I think it's just a better way to go.
If you get the Synthroid and Cytomel together, the amount of the copays combined will probably not be the same as the T4, T3.
Yeah, they're going to be cheaper at the end of the day. And it just, okay, take 3.5 tablets of this and 1.25 tablet. It's just like,
3 times a day, yeah.
it's just nuts.
For most of our patients to have that Armor ratio.
That's
it's not
4.5 to
much,
1.
But it's not much. It's not applicable to most of us because we usually use much more T3. So you might as well just create a formula that's what you want in one pill if you're going to go with some T4.
That's exactly it. And ITC, I would not use other compounding pharmacies for this because the T3 potency has been a real issue. So again, they have the standard combinations. It's basically 4.5 to 1, T4, T3.
But that's not the ratio we typically use. So.
No, it is.
Oh, of T4
To
to
T3, yeah. It's pretty close to the one in the Armor.
Well, in the Armor, but we don't use that.
No, the compounded, they have a 4.5 to 1. It's 38 to 9.
Yeah, the issue is that if you're using ITC, it's always a set unless you tell them to do differently,
Well, that's what I'm
which they
saying.
will do differently
That's
for
what
you.
I'm saying.
If you want a 50-50, they'll do it, but you gotta
Right.
write it.
I
Their
know.
traditional
You don't
is
want a
four-
50-50.
Oh, I understand that
If you
they're
go to
making
another
it like a
pharmacy-
traditional Armor. I
Yep.
understand that.
There is no standard at the other pharmacies. You have to tell them exactly what you want.
But Steve, what was your concern? 'Cause
Well,
I'm
no,
missing.
it's not really a concern. It's just that we can all create any ratio we want.
Right.
And if it's going to be, let's say, one capsule, rarely would it be probably that ratio of T4 to T3.
Oh, almost always when I do it, it's that
Really?
ratio. But let me tell you
Yeah.
a trick that I do with it. Unless I'm giving pure T3
Yeah.
and going up to the 120 microgram thing, that's a different story. I'm treating receptor resistance. But let me give a interesting thing. Nice thing about Gary now, I call Gary the mad scientist, and Alan too. They're wonderful. And when I come up with stuff, they have this tendency to be one step ahead of me. And I talked to them a while back, and I said, you really need to make thyroid T3 drops for sublingual use. Because what you'll find is that T4 has a half-life of 25 hours. So it doesn't matter if you give it once a day, it's going to stay at a set thing. Where the T3, the half-life's on the order of 4 to 6 hours. If you give enough T3 to get them feeling good in the early part of the day or later in the day, they're going to feel hyper in the beginning of the day. And then you have to split those. A nice thing is to use the ratio they have and then use T3 sublingual drops,
Okay,
where the one drop has 5 micrograms,
right.
and just have them take it PRN during the day.
Yeah, I understand, I'm all for that, because you don't need the time release T4. And if,
Well, it's
I
automatic
know
time
how
release.
automatic it is, but I mean, that's why it doesn't need to be in a formula.
Yeah.
But if you put a lot of T3 in with it,
If you put
then
enough
you want
T3 to
time
keep them
release.
high enough during the day, they're going to be hyper for part of the day and crashing for others. So this is a new thing. It's not very expensive. Ask them about it when you go, the T3 sublingual. Now they have a little syringe that draws up little tenths of a cc, and I think when you're drawing up that little, it's hard to squirt, but they're afraid with drops. Encourage them to make it in an eyedropper bottle and have the person look in the mirror when they do it so that they don't miss it and hit their shoulder or something. And then 1 drop is 5, and they can do 1 or 2 drops at a time just as a PRN thing. It is really a nice effect for people. And this way, during the day, it's just when they feel their energy flagging, a couple drops. Boom.
Had 2 people when I'm trying to get them off of the armor and just on
Mhm.
T3 or the T4, T3 that should equilibrate
Mhm.
that armor,
Mhm.
and it just does not work. They
Mhm.
get so tired, and I've had to put them both back on
Mhm.
just to get back where they were. And
Well, some of them may need the glandulars, the iodine, some of the other things that's in the glandular tissue itself. Check their TPO antibodies. If they're negative, what I would do is either just put them back in the glandulars. If you can't get it, get the T4, T3 combo, and then just do a thyroid glandular over the market. Standard process, enzymatic therapy, they have good glandulars for that.
and iodine, you think?
I think the iodine is very reasonable in our population, 1 tablet a day, period. Especially for a 3-month bottle. It's like the zinc. I think it's reasonable to have them get a bottle of Diodorol. Sue, we have the iodine available now in our own line. Yeah, just go ahead. The one caution with iodine is some people will get an irritated stomach, and if they're not going to make the association, just let them know that if they get heartburn from hell, to stop it. But most people, that won't be an issue.
Gary says something about the use of iodine is not needed if you've got reverse T3 levels, because it implies you're making
Okay.
enough. Okay.
Iodine has other functions besides thyroid in the body. And I think we don't know. And it's not going to hurt to give the 12.5 milligram,
It's highly
but
protective against cancers.
breast cancer
breast,
especially.
uterine, ovarian, and skin.
Any of the
Yeah.
glandular.
Yeah, it just, there's much more going on than just that. Good. Okay, let me go ahead and finish up with this. Again, you need the thyroid, the other function. We've talked about bowel infections. Leaky gut, keep your eye out in the future. This is an area that's going to be bigger as research comes along. Studies have the research shows that it is present in fibromyalgia. It puts a major stress on the immune system and causes food allergies. Remember, anything that your stomach and intestines do not digest that gets absorbed, the digestive process has to be completed by the immune system. You think about the weight of a viral infection. If there's 3 milligrams of virus, that's a lot of work. But you're eating a kilo of food a day?
Chuck, listen, there's some theories that this may be actually the cause of rheumatoid arthritis.
Absolutely, it's part of it, but also infections, bacterial infections that cross-react with the synovial tissue. I will give doxycycline in my rheumatoid arthritis patients, period.
endotoxins.
There may be, I don't know what the endotoxins, but I think there's a cross-reactivity, and Dr. Brown's work over 30 years now has been showing that the antibiotics in rheumatoid arthritis are effective. And then they had a study, they actually did a double-blind study showing it effective, and what did the doctors say? Oh, well, probably just the anti-inflammatory effect. It gets nuts. Let's just finish up over here. We talked about toxins again going on, but with the gut dysbiosis. If you have patients that are not getting better, check an ammonia level. Plasma ammonia. Jennifer, did we check to see what Quest is going to charge? It's just a simple plasma ammonia.
I can't remember now.
Okay.
I'd have to look through my email.
I don't think it's very expensive, and it's just a simple thing. Werner's been taking a look at a couple of them. You started somebody on the lactulose I saw. So let's see if it helps the brain fog and brings the levels down. But high ammonia reflects gut bacterial overgrowth.
It's $20.
It's about 20?
$20.
Yeah, it's not an expensive test, and the treatment's not expensive, I don't think. Sulfides. Kenny Demerlier, God bless his soul, came out with a recent newspaper thing, the cure for chronic fatigue syndrome and I'm not saying the cure, the cause had been found. And he says that it's because the bacteria in the gut are making sulfides, and the sulfides are toxic. Well, that's one of about a zillion toxic things being made. He has a new urine test. We asked him, Kenny, you know that that's a gross, bizarre overstatement. He says, but if you don't do it that way, the media won't pay any attention to you. Okay? So Kenny also is the one who recommended the hydrogen breath testing, if you remember when he came to speak at FFC. And he's,
Philadelphia Center piloted that.
yeah, and it was like, so it's kind of teaching me again to be a little more of a skeptic in my old age, or my young age, whatever. But again, he's recommending a urine test. That if you shake the urine, it'll turn dark and say, oh my God, I got CFS because of sulfides. Well, the amount of sulfides that it would take to turn the test positive, or made by the bacteria, before it would get toxic, you'd have to have about 1,000% more. Have you ever smelled a natural gas leak? Like rotten eggs? That's because they put the sulfides in the gas so you can smell it if there's a leak. It takes about 1,000 times that concentration before it gets toxic. So basically, instead of the fancy urine test, all you have to do is see if you have stinky flatulence. And it'll tell you, because that's sulfides. Now, if every fat little kid and boy in high school with stinky farts was going to be dead, we'd have a playground full of, So that's not.
That's like in the Ann Louise Gittleman's diet, the Fat Flush Plan, which changes your diet dramatically. That everybody reports flatulence is almost odorless.
Well, the fiber, yeah, that happens, but it's odorless because there's not the bacteria. There's the increased fiber causing the flatulence.
And then she says, as you add food back in, you may notice, like the cruciferous vegetables, obviously,
Yep.
more sulfur. So that's the question: what is the cause of that? Is it food or is it bacteria?
Well, you'll find that as you change the food, you're going to change your bacterial growth because acidity and the whole thing changes, and your body will adapt back too. So the sulfides, and some foods will release, but usually it's going to be the bacterial production. Treatment, we don't know, but bottom line is if you give Pepto-Bismol, bismuth turns the sulfides into sulfates, so they're non-absorbable and get kicked out of the body.
And then you got to warn the patient.
It'll turn the stool black. Otherwise, they'll call the emergency room in the middle of the night, and they'll go and they'll do the whole melano workup, and boom. So warn them, iron or Pepto-Bismol. Let them know that it will turn the stool black. Now, it won't make it smelly. Those of you who remember working on the GI ward, you could tell a GI bleeder from about 2 wards away. But it'll be black, but it won't be this foul smelling. Just warn them ahead of time, just iron and the bismuth. Bismuth also breaks up biofilms. Another big issue for another day. So again, we've talked about this biosis before and most of these other things. One other thing I want to do before we break, do not forget celiac disease. I just want to talk about 2 diagnostic treatment things quickly. 1% of the population has celiac disease. That's a genetic wheat allergy. Celiac disease mimics chronic fatigue syndrome. I still remember the first patient I saw with celiac disease. I was about a year out of training, and I was on call in the emergency room, and this woman came in looking like a cachectic cancer patient, no insurance. I was working at a HMO at that point. We snuck her into the HMO. Sorry, I shouldn't hear this. Did the workup, found she had celiac disease. She came back 6 months later, this robust, healthy-looking woman, having looked like this, Auschwitz survivor kind of person when we saw her. Celiac disease will not respond very well to shine, and it looks just like CFS. Very simple to diagnose. IgE anti-transglutaminase antibody. High sensitivity, high specificity, Quest does it, standard blood test. Easy. People that are not responding at 3 to 4 months, do an ammonia level, do an anti-transglutaminase. If the anti-transglutaminase is positive, you take them off the wheat, and you're going to find a lot of their symptoms will go away. 1% of the general population, 4% of the population with IBS. And since we have people with IBS from hell, I'm going to guess that we are missing a lot of this. And something I should have been checking for 30 years, but I'm a little slow, as Andre will attest to sometimes, to pick up some of the new things. And it's, but again, test it in all non-responders. Put it on your list to do. We should add it on our list next time we update the forms.
Going back.
Well, let me go ahead first.
I've had patients that I've checked and it has come out negative,
Mhm.
but empirically they've cut out the wheat.
Oh, wheat
They
allergy,
feel-
there's a lot of people who have wheat allergies who don't have celiac, because when you have the poor, the dysbiosis and the leaky gut, wheat and milk are cross-reactivities, and it's perfectly reasonable to do an elimination diet. Again, I am not a big fan of the allergy testing, blood allergy testing. I think it's horribly unreliable and neurotic making. But it's very reasonable to do an elimination diet, very reasonable to cut wheat out. But what you'll find is in that population, you clean up the gut and digestion, and they get better 6, 12 months later, you can add the wheat back in. In this population, you can't. So, and yeah, I'm not saying this rules out. I'm saying it looks for one that it's easy to test for and to do. I'm just going to go through over here. I want to note for the nasal congestion and sinusitis, anybody here not using the sinusitis nose spray with people with nasal congestion? It is awesome. Use it. Anybody with sinus congestion and sinusitis, the patients love it. Do it along with the diflucan and the rest of the anti-yeast probiotics. At ITC, that's where they make it. I've had them make it at other pharmacies and it burns. ITC is very good at buffering their stuff so it doesn't. Blah, blah, blah. The one other thing I want to talk about is low-dose naltrexone. Again, naltrexone is an opioid blocker. It's used in drug addicts to keep them from getting the high. If somebody comes in with an overdose, they'll give Narcan and wake them up. You know, that's IV form. Naltrexone is remarkable in that total different doses have a different effect. The 50 plus to 200 milligram dose blocks narcotic effects in drug addicts. 3.5 to 4.5 milligrams suppresses cytokine-induced hypothalamic dysfunction, can augment immune function and balance it. But you use a higher dose, you totally lose that effect. When you go down to microgram levels, about 8 thousandths of a milligram, you augment the effect of narcotics and decrease the amount of pain medication. This is a rather remarkable agent. But there's more and more work looking at 3.5 to 4.5 milligrams. I think ITC can compound that in capsules. Good. It's cheap. It's like $40 for a month. Give it a 6-week trial. I tried about 15 years ago. It didn't work, but I think that's because I gave them 2-3 weeks. It wasn't long enough. But just have them try at bedtime, 1 capsule. More is not better. The one study showed a 60%
Capsule or solution?
capsule.
Oh,
Is ITC making a solution?
it's a solution.
However it is.
So they're making a capsule.
Most people have it in a capsule, but I'm not sure.
Don't you titrate up
No.
with your patient?
You can go to 2.5 up to 4.5, but I think it makes more sense to start at 3.5 to 4.5 and leave it there.
Just 4.5.
Yeah, the standard dose anywhere in this range. Maybe if they're little people, you can give them like, the lower dose. If they're, more people of substance, you can give them a higher dose. But anywhere in that range. But more is not better. But I would give it a 6-week trial. Have them get a bottle of 60, and they'll know by the end of that. 60% response rate. But the interesting thing is the people who had a higher SED rate were more likely to get better with it. And since most people with this disease have a low SED rate, it's a very nice discernment to see somebody with a SED rate over 10 or 11, maybe reasonable, because most of our folks have 3, 4, 5. It's very reasonable to just put them on the naltrexone. It's a quick, easy thing while you're doing everything else. So anyway, I want to thank everybody for being here. I know we took a good bit of the time kind of doing questions as we went along, but why don't we keep taking questions? And the questions are for anything. And I'll open the floor also to assistant medical directors. We can throw questions to everybody. Okay, Mark?
I was going to say, when we talk about using lactulose, can you also use xylitol for treating gut dysbiosis?
Not that I know of.
Okay, because then supposedly they're using it in nasal sprays.
Well, the xylitol is an osmotic. What it is the concentration is so high, it's as if you're putting something in honey or salt. You suck the fluid out of it, and it kills the organisms in that way, is my understanding. To get that high of a level in the gut, because think of the surface area
Yeah.
of the nares versus the surface area of the lumen of the gut. I don't think you're going to see the same effect. By the time you get that high a level, they're going to be clearing the dysbiosis because they're going to be pooping a gallon a day from the
Lactulose
osmotic.
does the same thing.
The lactulose does it, but if you have a lesser amount, the lactulose, I think, binds or kills. I'd have to look up the mechanism again. Lactulose, I think, converts the ammonia to, I'd have to look it up, it converts the ammonia to inactive form that gets pulled out.
The question is, if we converted people to using xylitol as opposed to regular sugar, would we increase their intestinal?
Well, let's just say if you give them a gas mask along with it, you will increase their intestinal transit time. Well, the transit time will speed up. But again, the sugar alcohols are non-absorbable, so by definition, they suck water into the gut, and beyond a certain point, pull things through.
So be more careful with the hypovolemia also.
That's not going to be good for the hypovolemia. Good. Okay, the floor is open.
There's a couple of things I wanted to just go over with you while we're together as a group, as a follow-up from yesterday's conversation about the packages. Because there's been a lot of questions that have come up about the viral patients. And if you remember on the slide, there was that issue of, is it or is it not included, and what's all-inclusive mean?